Today, the topic that has been allocated to me is the management of PCR test for anterior segment surgeons. Hello, I am Dr. Abhishek Anand. I am Associate Professor at RIU IGMS Patna, and I don't have any financial interest for the above. Well, I will begin my presentation by first a disclaimer that PCR is a known complication. It can happen in best of the hands at any point of cataract surgery, and successful implantation of IOL in the bag or sulcus with complete removal of lenticular matter and vitreous gel should be our goal in the same setting. Many alternative techniques currently exist which give, and this is most important, that they give almost same results as an uncomplicated phaco. So in order to avoid that, in order to achieve that, a badly managed PCR should be best avoided. And what is the first step in a good management of a PCR is that you identify it early. And early identification can be a game changer in the PCR management. And how do we identify it early? There are certain signs that we have to identify is a sudden deepening of the anterior chamber, sudden transitory appearance of a clear red reflex, inability to rotate a previously mobile nucleus, excessive lateral mobility, or the loss of nucleus followability in the phaco-tip, excessive tipping of the one pole of the nucleus, or partial descent of the nucleus into the anterior vitreous space. And these are the telltale signs that a PCR has happened. And if you identify it early, this could go a long way in how we manage it. No, one of the goals of the management of PCR would be to avoid the posterior dislocation of nucleus. But to avoid a posterior dislocation of nucleus doesn't mean a wild fishing maneuvers that we should undertake. It can be safely done in a very controlled way. You minimize the collateral damage to the corneal endothelium. They prevent enlargement of the tear. And why does the PCR tear enlarge? Is mainly because the vitreous prolapse and it tears apart the two lips of the PCR. And we must respect the capsule. We must prevent to the damage to the capsule plexus and avoid traction to the peripheral retina and do not create a peripheral break. And removal of leftover cortex is one of the paramount importance because adherent cortex in left behind can cause to chronic inflammation in the long term postop. And one of the most important is the proper positioning and centration of the IOL and avoid undue high estimated in the course. The management strategies would depend on the following things and it can differ. And these are the points that will determine which type of IOL you'll put, what strategy you are going to take, and what is the eventual outcome. One of the most important is the extent of posterior capsule tear. That will determine whether you are going to place in sulcus or in the bag, or we'll have to adapt to a scale fixated IOL or an iris fixated IOL. Intactness of the hyaloid face is another very important aspect. If you have a very good intact hyaloid face and you have a small PCR, you can just do a posterior capsulorhexis and you can go for an in-bag IOL implantation. Now, location of the nucleus, whether it has been dislodged into the vitreous cavity is very important. If it has been dislodged into a vitreous cavity, you can go for an sulcus fixated IOL in the same setting, or you can have your retina prac colleague help you out with the removal of the nucleus along with a sulcus fixated, scale fixated, or an iris fixated IOL. Another very important is where you are practicing, whether there are vitreous cutter, vitrectomy machines, and the VR surgeon and setup is available or not. Also, the availability of alternative IOs sometimes is not present at the same setting. So these all variables determine how you are going to manage a PCR. One of the earliest response to PCR is the urge for sudden removal of instrument, and that should be best avoided. Unplugging of the incision will result in emptying and collapse of the anterior chamber. Anterior chamber should be filled with viscoelastic through the side port incision to block vitreous prolapse and stabilize any remaining lens material prior to removal of the phaco or the IA handpiece. The surgeon should stay in the foot pedal position 1, and as the viscoelastic is injected, he should change the foot position 0, and the hand push can then be safely removed after the anterior chamber is filled and the viscoelastic is plugging the posterior capsule rent. Now look at this case scenario. You can see on the left hand is filling the anterior chamber and plugging the viscoelastic. And once we have done, then we remove the phaco handpiece. And here you see the vitrectomy cutter is going behind the PC rent, going behind the PC rent and trying to remove the vitreous. And us an urge to remove the phaco handpiece was well avoided. Which viscoelastic? Now the dispersive viscoelastic agent should be injected to plug the posterior capsular tear. Nuclear material should be moved into the anterior chamber with a spatula and emulsified into short bursts. You should use low phaco parameters like low Voidal height, low flow rate, low vacuum, and low ultrasound power. Attempts at retrieval of dislocated nucleus carry high risk of creating peripheral triangles, so no fishing. Removal of the remaining cortical material should be attempted with preservation of the anterior and the posterior capsule. Now look at this case scenario in which we are trying to remove the epinucleus. Let's look at again in a slow maze, and we see that this tip hits the posterior capsules and creates a large circular posterior capsular rent. So how to go about? So in this case, we have injected the viscoelastic, and once it is injected, we use the IOL that is planned for the surgery to be placed as an IOL scaffold, and this will help. This IOL scaffold will the vitreous to prevent the vitreous to come into the anterior chamber, as well as it will act as a scaffold over which the phaco can be done safely. Now this IOL is, since it's a this IOL is placed in the sulcus, and now we continue with completing the removal of the epinucleus matter with the phaco handpiece. And once we have done that, we can see that with this epinucleus is removed, we go behind the IOL, and after doing the vitrectomy, we remove the remaining cortex. Now, removing of this cortical matter is of paramount importance. Also, we look and check for removal of any residual vitreous. Now, this can be as large as this nucleus on which the post hydrodissection, there was a complete tilting of the nucleus. Once there is a complete tilting of this nucleus is rotated by using the Sinskey hook into the anterior chamber. After rotating into the anterior chamber, the planned IOL is injected into the sulcus, and this acts as an IOL scaffold. And over this IOL scaffold, the rest of the phaco would be completed. Now, this can be done very safely because we are using a torsional handpiece, and this will minimize the collateral damage. However, if this is a very hard cataract and we have only availability of the longitudinal power, this might cause collateral damage. So multiple times injection of the viscoelastic, covering of the taking proper care of the corneal endothelium by multiple injections of the viscoelastics is of paramount importance in this case. Once we have completed this IOL scaffold has very well prevented the the vitreous to come into the anterior chamber. Now we go for completion of the anterior vitrectomy. We are using the Centurion system, and we again used a diluted triamcinolone acetonide to look for any residual vitreous into the anterior chamber. This triamcinolone acetonide can be used to delineate any vitreous and should always be used whenever accurate delimitation of the vitreous fibers is required. And naked eye exam, I mean, the just not should we should not be dependent just on the naked eye examination. Now, one of the basic principles of vitrectomy in the PCR management, anterior vitrectomy should be performed so as to allow closure of the wound without vitreous incarceration. And this is one of the most important steps because vitreous incarceration into the side ports or the main port can lead to future endophthalmitis as well as recurrent traction to the peripheral retina and subsequent development of peripheral breaks. Secondary removal of dislocated nucleus through three-part pars plana should be planned. For the parameters for anterior vitrectomy, use the maximum possible contact rate that is available in your machine. The vacuum should be around 200 to 300 mm of Hg and low flow rates. So how do we determine the flow rate? This should be around 10% of your vacuum. The vitrectomy tip should be inserted through the opening in the posterior capsule and placed a millimeter or two behind the posterior capsule. The aspiration port should be directed upwards towards the cornea. Why it is important? Now look at these two diagrams. The diagram on the left is when the vitrectomy port, the vitrectomy probe is just above the PCTA. So what is it is doing is it is effectively pulling the posterior vitreous more into the anterior chamber. While if we put the hysterectomy port few millimeters behind the posterior capsule tear, so all the prolapsed vitreous will come back into this. Also, the mouth of the vitrectomy cutter should be facing upward so that all the prolapsed vitreous. We must remember that vitreous is a gel and we should not be fishing around it and running after the vitreous. Over the wall of the vitreous gel will come automatically. We just need to center the vitrectomy port here. Begin the vitrectomy dry and then infuse BCASS gently if the chamber tends to collapse through the side port. More vitreous will prolapse if the pressure in the anterior chamber is low when the aspiration continues. So we must give a side port infusion. The vitrectomy pit should not be placed through the primary phaco-incision and the urge to do should be avoided because the incision is in the wrong size for it. And you should never change the vitreous. Vitreous is a gel and it will automatically come into the vitreous vitrectomy tip. Let's see it with another example. Now this patient was blind for a combined phaco with PPV, and these are the steps of a retina surgeon. But this video emphasizes that tends to show that few of the steps can be done by the anterior segment surgeon also. So in this, what we see is that the infusion port has been done. And since we already had a plan for a 3-port pars plana vitrectomy, so we continued with, first of all, introduction of the vitrectomy probe into the near the vent. So here is the rent. This is a triangular rent that is present. And we are aspirating the prolapsed vitreous into it, through it. So all the prolapsed vitreous that is come into the anterior chamber is aspirated back. But an anterior segment surgeon can also do the same by introducing it through a side port incision. So here is the infusion part and here is the vitrectomy probe. Now, one of the advantages that the vitrectomy probe gives you that you can use it alternatively as a suction as well as a cutter. So we are aspirating as well as cutting the fibers. So the undue tractions to the peripheral cortical vitreous is not done. So what we see here is that The vitrectomy probe is effectively being used as a suction port and it ensures in complete removal of the cortical vitreous. Now see it with another example. Now this anterior segment surgeon has a drop nucleus. We can also see that there is a very nice capsular axis which is left. I begin by inserting this IOL into the sulcus because I know there is a dislocated nucleus. I am 100% sure how to go about it. First of all, I ensure the well centration of the pressure. Now, this is a very important step. This is the step where you can give to a retina surgeon if you have a posterior dislocated nucleus that you put an IS in the sulcus and suture the main port. We began by doing the vitrectomy. What we see here is that the IOL is in the sulcus and there is a lot of cortical matter which is left behind. So what we do is we begin by the anterior vitrectomy and then we use the vitrectomy probe for alternate suction and removal of the cortical matter. Now this helps in a beautiful removal of the cortical matter without any undue traction to the vitreous fibers. And why is it so? Because the cortical matter, whenever it's done, we cut it, and this transmission, this ensures its effective cutting of the any entangled vitreous fibers. After the complete removal of this, the next steps are very easy, in which I try to capture the iron in the capsule access manager. We do an optic capture, and then we proceed with the usual three-port pass planar vitrectomy with removal of the dropped heminucleus that is performed. And once the dropped heminucleus is removed, one of the very important steps as a retina surgeon is staining of the cortical vitreous. And once we have removed it, we stain and look for the cortical vitreous, and we do a complete posterior vitreous detachment with a complete removal of the vitreous. So, to conclude my talk, identify the presence of predisposing factors and appropriate modification of the surgical plan. Be ready for it. Whenever it happens, do not panic. Early recognition and treatment of capsular tear and vitreous loss prevents serious complications and improves postoperative outcomes. Take time to ponder. Always take a time to ponder what will be the best surgical strategy in an event of PCR. In case of doubts, discussing intraoperatively with colleagues, mentors can have long-term implications for the successful outcome of the surgery. Take help of retina colleagues whenever required. Discuss, and this is one of the very important medical legal aspect of a case, is that whenever you have PCR, discuss with your patient post-operatively and explain the intraoperative and future management strategy. With this, I end my talk and I would like to conclude it. Do what suits you the best. All the best. Thank you.